So welcome, everyone. My name is Barbara Currie, and I'm going to be the moderator this evening. Happy to have Dr. Chris Ma and Dr. Tom Appleton here tonight, and I'm going to share their bios here in a minute. Our presentation tonight is exploring the ImmUniverse, a Cross-immunology summit, and tonight we're going to be focusing on rheumatology and IBD. Before we start, I'd like to thank our sponsor tonight, AbbVie, for their generous support of our CAN-IBD programs. So CAN-IBD is a consortium of nurses across Canada working in the field of IBD and is supported by Crohn's and Colitis Canada. And for many of you, you know our vision is to ensure people of all ages living with IBD in Canada receive high-quality clinical nursing care within a multidisciplinary team. And having webinars such as this enable us to share experiences and gain knowledge in the management of our complex patients. We're committed to providing quality of care for people living with IBD by providing mentorship and learning opportunities such as this evening, creating opportunities for networking and sharing of best practices, and developing and adopting nursing guidelines and standards for IBD nursing in Canada. And of course, we want to elevate the profile of IBD nursing in Canada. So without further ado, Dr. Ma is a gastroenterologist and associate professor at the University of Calgary. His clinical and research expertise is in the management of inflammatory bowel disease and clinical trials. This is his longer bio here.
And please don't read it.
As well, we have Dr. Tom Appleton. Dr. Appleton is a rheumatologist and head of the Division of Rheumatology at Western University in London. His clinical and research expertise is in the management of systemic autoimmune rheumatological diseases and the role the immune system plays in the regulation and resolution of inflammation. So tonight, I would like to thank all of our sponsors that support us in CAN-IBD. And without further ado, I think that is my last slide, and I will stop sharing and turn the presentation over to Dr. Appleton and Dr. Ma.
Wonderful, Barb. Thank you so much for that lovely introduction. And I would applaud CAN-IBD for its mission in being able to bring not just, as you said, guidance and a number of initiatives, but also education to IBD nursing. And as a rheumatologist, I can say we are totally jealous of the incredible network of IBD nurses across Canada that are helping to support the care of patients with IBD. In rheumatology, we don't have nearly the same network established, and we are certainly interested and very active in models of care. But I get to work closely with many gastroenterologists locally and afar, and marvel at all that you do. So welcome. It's my pleasure to be working here with Dr. Ma, Chris, and we're going to be sharing with you basically a snippet of a session that we put together started working on about a year ago together with our colleagues, another rheumatologist, Dr. Rohaker, another gastroenterologist, Dr. Marshall, and a couple of dermatologists who I'll introduce you to here in a second. And so the focus tonight is really on the IBD piece of this and how that interacts with rheumatologic disease and vice versa. And we'll do that in a case-based presentation. But recognizing that there are other immune-mediated inflammatory diseases that our patients frequently have, and certainly in the dermatology sphere, this is part of a wider program. So this is what we wanted to talk about. And so, you know, in keeping with the space theme, we're starting with mission control, welcoming all of you. And this is our faculty who I was just alluding to. So I've already mentioned Dr. Ma and Dr. Marshall. Dr. Kim Papp is in Waterloo, a dermatologist. Dr. Melinda Gooderham is a dermatologist in Peterborough, and the six of us work together to help put this program together. So hope this is enjoyable for you. These are our disclosures, and of course, AbbVie is supporting tonight's event. AbbVie has also supported the development of this program, and we thank them very much for that. And all of us have a number of disclosures here. So these are mine, Dr. Rohaker's and Dr. Gooderham's, Dr. Pabst, Dr. Maz, and Dr. Marshall. Okay. We also need to point out that as speakers, we choose to speak about different products, and sometimes we even talk about unapproved uses or even uses off-label, and so we'll tell you if that's actually what we're talking about, and that might actually come up tonight. AbbVie doesn't support any discussion of the use of products that are off of its product monograph or so-called off-label, so just reminding you about that. We, as the experts, have developed the content here. Obviously, it's being presented through our own lenses and own opinions, so take that for what it's worth. We had full editorial control of the slides, and AbbVie is providing the sponsorship. So those are our disclaimers. We are broadcasting across the country, and so what we're going to try to do is go through a couple of cases. We'll ask you to engage by answering a couple of poll questions, and there's also the opportunity using the Zoom chat to submit questions. There's a Q&A button, and so please find the Q&A button. It could be at the top of your screen, it could be at the bottom of your screen. As we're going through, if you have questions now that you want to make sure we answer, or if you have questions that come up as you're listening, please submit them. And Barb, as our moderator, is going to help pitch those questions and make sure we get to them before the end of the hour. Good. So our objectives are to focus on the context where patients have multiple immune-mediated inflammatory diseases. We know that there are close relationships to those, and we'll talk a little bit about what might be behind those interrelationships between patients with multiple immune-mediated inflammatory disease. We'll talk about referral pathways and ideal management strategies, and of course, there's the ideal, and then there's reality, and we'll talk a little bit about how to navigate that. And ideally, we'll also evaluate some best practices and how we co-manage across different specialties. And really, that involves very much working with our experts in allied health, including nursing, but also in rheumatology. We also work with a number of other disciplines, health disciplines, to extend our role and provide care. We've got about 20 minutes assigned for each case. In truth, the first case is a little bit longer. The second case will be a bit shorter, and then we'll have hopefully a good 10 to 15 minutes for discussion and question and answer. So please do submit your questions. In the content that went out, there were a couple of links to video capsules, and don't worry if you didn't have a chance to see those, you can still view them later. But I just wanted to give you the bottom line from a couple of those videos. So the first capsule was really talking about the fact that if you have a patient with an immune-mediated inflammatory disease, the chance of them having a second one is far greater than the risk of developing an immune-mediated inflammatory disease in the first place in somebody who never had one. And this risk can be as high as 60-fold greater to have a second immune-mediated disease. And in rheumatology, we often will see patients who have hypothyroidism and rheumatoid arthritis and type 1 diabetes. That cluster often goes together. And in GI, you would see inflammatory bowel disease and psoriasis, or with axial spondyloarthritis. And it turns out that a lot of the risk for this is probably genetic. There are clearly environmental factors as well, and in truth, it's probably the two of these different things working together. But we know from a lot of different gene typing studies, or GWAS studies, that there are over 100 different gene abnormalities that are associated just with rheumatoid arthritis, and only 2 of those changes are associated with rheumatoid arthritis alone. The other 98, they can be associated with other autoimmune diseases, other inflammatory diseases. And so there's a tremendous overlap in the risk for developing immune-mediated diseases. And that's probably the reason that we also see shared mechanisms. And the mechanisms, of course, go to what the therapies are. So it's not a surprise that TNF, or tumor necrosis factor, is involved in driving disease in immune-mediated inflammatory diseases in both GI and in rheumatology, as is the interleukin-23 pathway, as are things like the JAK-STAT signaling pathway, really mediating a lot of those inflammatory mechanisms. So there's a lot of overlap, and people are at high risk of getting multiple diseases. The second video is really focusing on what we have in common and then how we start to look at the unique nuances or differences. So we have a shared goal, and our shared goal is we want to stamp out inflammation. We want to suppress inflammation because we know that prevents damage, prevents disease progression, and ultimately gives the best outcomes possible for patients. And that's common across dermatology, across rheumatology, across gastroenterology. But even though we have this goal in common, there's a lot of different ways that we do it. And in rheumatology and dermatology and gastroenterology, we're measuring different things. We're thinking about different reasons why we would pick one mechanism of action or one medication or a combination of medication over another. For example, dermatology would rarely, if ever, combine medications, but that's almost the rule, not the exception in rheumatology, and often in gastroenterology, there can be combinations as well. So when we're co-managing patients with multiple immune-mediated inflammatory diseases, we need to be aware of what the other specialty is doing. We need to understand the severity and the spectrum of disease for the other specialty and be assessing that, and then working together, working with the patient, factoring in patient preferences. So it's upping our game in terms of complexity and in terms of the number of interactions, both with the patient and with other specialties. So it's very interesting. So let's take a look at this and put it into action with our first case. So this is cross-specialty case number 1 with Stephen. He's a 62-year-old man who has psoriasis and psoriatic arthritis. So has been followed by rheumatology. Had, unfortunately, cardiovascular disease, so had a myocardial infarction about 5 years ago. And in a good way, he quit smoking, but he's still at high risk because he's got an inflammatory disease. He presented initially with pretty bad mutilating psoriatic arthritis, so joint damage in his wrist, in addition to dactylitis and enthesitis, which are quite painful and with rapid destruction, and very quickly went through a number of different therapies. Started on methotrexate, only had partial improvement. Added leflunomide, only partial improvement, and then relapsed, had to go back on it. No response to sulfasalazine, essentially no response to a TNF inhibitor with adalimumab. Had a good skin response, so psoriasis got better with ixekizumab and also with secukinumab, so blocking IL-17, but unfortunately really no benefit for the joints in that case. And even better response with guselkumab, the IL-23 inhibitor, but really not an improvement in peripheral joints. So currently he's on upadacitinib, and we moved him to upadacitinib in addition to methotrexate and leflunomide, got a good joint response. And now is what we consider to be MDA, or minimal disease activity, which means your psoriasis is good, your joints are good, maybe has pretty good control of pain, but not a lot of other things going on. So in a pretty good state from a psoriatic arthritis standpoint. But new information comes up, and at his most recent visit, he complains now of having bloody stools and mucus and abdominal cramping. And so our spidey senses go off. We say, oh no, this person's at high risk for developing a second immune-mediated inflammatory disease. It's probably going to be either UC or possibly Crohn's disease. We refer to gastroenterology. They do their workup, get a fecal calprotectin, get the endoscopy done, and sure enough, this is in keeping with IBD. So what do you do? And this is where we want your input. So please take the opportunity to answer the poll question. This should pop up on your screen momentarily. So the question is, how would you manage Stephen in this case? Would you change the dose of the upadacitinib, the JAK inhibitor that he's on right now? Or B, would you switch to a different class of medication? Or C, some other regimen that you have in mind? So please answer that, and we can take a look at the results as soon as those are available. Just give a moment for that. Okay, let's see what we got. All right. All right, very interesting. So it looks like the majority want to modify the JAK inhibitor dose, presumably to an IBD dose. We'll talk about that. One person wanted to switch to a different treatment class, and nobody has any other creative off-the-books ideas. So let's go with that. Great. Okay, so Chris, why don't we bring you in here and kind of get your thoughts. When you think about using JAK inhibitors, you're probably thinking about different doses than I am. So what's your take on JAK inhibitor dosing?
Perfect. Thanks, Tom. Appreciate the invite to be here tonight. It makes me very proud seeing the results of that poll because it goes to show how like the level of I think a really, really high level of care that's provided by IBD nurses around the country. And I think, when we did this live in Toronto a few months ago, I think there might have actually, if I remember correctly, there's a bit more discussion about, other options. But I think I probably would do the same thing that's been chosen here, that I'd think about the dose. And hopefully that represents, or I think it reflects some of the, I think it really reflects the game that the IBD nurses have. Like they're really, really talented, and I speak from having really talented IBD nurses at my site, so I feel very, very proud internally. We can go to the next slide. And Barbara, I saw that there's a question on the chat about methotrexate and the JAK inhibitor, which we'll hopefully cover in a few, maybe we'll cover after the next couple of slides here. So, Tom, I think you're right. We across dermatology, rheumatology, and GI, we all use different doses of all of our advanced therapies, actually, not just a JAK inhibitor, but for many of the biologic therapies, we use different doses for induction, for maintenance. I think many times we felt that in IBD, we use very, very high doses of therapies. And historically, we felt that that's probably been for a number of different reasons. One is that when patients are sick, we know that there's some leakage of drug in the bowel. So there's leakage of drug from tissue into the stool. And so whether or not we are getting the same level or same concentration of therapy at the site of inflammation, I'm not sure that we're always confident in that from a GI perspective. Secondly, not to toot our own horn, but sometimes we feel that IBD can be one of the hardest manifestations of inflammatory diseases to treat. And that can be for a number of reasons. That can be because of the burden of the disease. That can be because of just the volume of tissue that's involved. That can be because there's been progressive damage to the bowel over time. And so often we've seen, in GI, these very, very high doses of therapy administered in induction and then in maintenance. With biologic therapies, I think we haven't really had to pay a penalty for that. There's been really good studies of very high dose biologic treatments administered and really no difference in safety between very, very high doses and what we'd maybe consider standard doses. That's probably not the case, though, for small molecule therapies. So both JAK inhibitors and for now we have S1P receptor modulators for ulcerative colitis. For those two classes of therapies with oral treatments that are not very specific monoclonal therapies, the dose penalty that we pay, I think we have to think more about. So this is the approved dosing. You can see the approved dosing for both upadacitinib and for tofacitinib across multiple indications. Highlighted here the psoriatic arthritis indication, where the dosing for upadacitinib is 15 milligrams for UPA, 5 milligrams twice daily for tofa. And then you can see the Crohn's disease and ulcerative colitis indications at the bottom of this slide. We use 45 milligrams daily dosing for 8 to 12 weeks, whether it's ulcerative colitis or Crohn's, for induction therapy, with the recognition that in ulcerative colitis, there was an extension program where you could use up to 16 weeks of 45 milligrams once a day. So about triple the standard dose that we use in psoriatic arthritis. And then for tofacitinib, of course, there's 10 milligrams BID for 8 weeks for ulcerative colitis, and then a 5 milligram maintenance dose. So you can see there is some dosing flexibility here. One of the important questions is, do you get more for more dosing? And if you go to the next slide, we can explore some of that in the pivotal trial program. So this is the phase 3 data from ulcerative colitis. And so you can see gray bar here is placebo. The dark, I think that's purple, but I'm probably not up to date on my Crayola colors, but I think that's purple. On the left-hand side is the week 8 data, and then on the right-hand side is the week 52 data. So what you see on the left-hand side, everyone on the left-hand side has gotten 45 milligrams of upadacitinib compared to placebo. The primary endpoint was clinical remission, and then on the bottom is what we likely would consider our treat to target goal. So that's endoscopic remission, which is, this is very difficult to achieve. This is complete normalization of the mucosa. So you put the camera in and it looks perfectly normal. And you can see the treatment deltas in these there's 2 induction trials, and you see the treatment deltas, they're somewhere between about 15% to almost 30%. So very, very high rates of induction. That's over placebo. So for context, I think most of the time in a trial, if we can get to 15%, it's time to pop the champagne, because that's going to be a positive trial. On the right-hand side is what happens in at week 52. So this is how well does it maintain it long-term. You can see that over half of patients on the 30 milligram dose are in clinical remission at a year. And the second thing you see in this slide is that there does appear to be a dose response, that the higher that the dose that you are maintaining the person at. So comparing the light purple, which is 15 milligrams, to dark purple, which is 30, the higher doses tend to do better. And we've seen this pattern across effectively all of the JAK inhibitors that have been studied. So UPA and TOFA are approved here. In Europe, there's another JAK inhibitor called filgotinib that's approved. All of them have shown the same pattern, that the more you give, the better it is. But the more you give, there's also a trade-off, which is the safety profile of the therapies. Go to the next slide. And this is the same data that I showed you before, but this is the data for tofacitinib. And again, straight off, what you can see is that same dose response pattern for 5 milligrams to 10 milligrams still exists. And then the treatment differences here are a little bit less pronounced. So this is a different trial program. Actually, this trial is, patients here are a little bit less sick than the upadacitinib trials. They've had less treatment exposure than the upadacitinib trials. And despite that, you can see that the treatment differences against placebo are maybe slightly less pronounced, probably about half of the deltas compared to upadacitinib. Next slide. So what's the safety penalty that you get, I guess, is one of the major questions. And we'll start with 45, because 45 is obviously the highest dose. So this is really the maximum dose that was allowable in the program due to tolerability. Yeah, I've shown you the efficacy of 45 milligrams, which is really, really potent. And, I think now across multiple comparisons, at least 5 different network meta-analyses now, I think it's pretty clear that 45 milligram upadacitinib is the most potent ulcerative colitis therapy. And you've now had about a little bit more than a year now of experience with using upadacitinib. In many ways, it's somewhat addictive in ulcerative colitis, because it's incredibly fast in terms of the onset, and then very, very potent in terms of the efficacy. The knock on this has, of course, been safety, and how safe is 45 milligrams. So I think probably some of you have heard me say that I think there's 4 horsemen of the apocalypse when it comes to upadacitinib or JAK inhibitor safety. They're herpes zoster, cancer, MACE, and VTEs. These are the things that are in the news that make people worried, about using a JAK inhibitor. And so what you see in this slide is the safety at 8 weeks of upadacitinib 45 milligrams versus placebo. What I'd say for this is there is definitely 100%, no doubt, a signal for herpes zoster. There's 3 cases here that I've shown you. Actually, if you look at the extended program in Crohn's disease, which is 12 weeks of 45 milligrams, there's 10 cases in the Crohn's disease program, 100% herpes zoster is a risk, and it's a risk that happens because of immunosuppression. So the good news about that is it's a risk that's preventable. So in this program here, there's 5% of the population that's vaccinated. And I'd say if we only vaccinate 5% of the IBD population, maybe we're not having the best day in the office. And then if you think about the other horsemen of the apocalypse, the things that make you worried, there's no cases of cancer. There's no cases of non-melanoma skin cancer. There's no cases of MACE, and there's one case of a VTE, but that happened in someone who's getting placebo. So there's no cases of VTE in the UPA program. And so I think this table is actually very reassuring about the 45 milligram dose. Similarly in Crohn's disease, so 12 weeks of 45 milligrams in Crohn's disease, there are similarly 0 cases of cancer, 0 cases of MACE, and 0 cases of VTE. So I think between the two programs, we're talking about over 1,000 patients that have been exposed. It looks like induction efficacy at 45 milligrams is actually very, very safe when it comes to the things that make you worried. The one counter argument that often gets brought up, and you'll hear it all the time, is people will say, well, who cares, right? It's 8 weeks of exposure or 12 weeks of exposure. I don't care about that because it's too short of a time period to see these events. And while I think that there's good merit to that argument, the flip side to that is you have to remember in the trials, you can't progress if you didn't get better after induction. If you did not respond to induction therapy, you don't move on. So that's real life too, right? In patients who don't get better after 8 to 12 weeks, if you're not better from an IBD perspective, we're not going to keep banging our head against the wall with a therapy that doesn't work. And the likelihood that you're not going to be better is very, very small on a JAK inhibitor. The other thing to take into account is the fact that if you are better, you've won. This is a difficult disease to treat. If you can respond to a mechanism of action that can get you into remission, that is a win. And there's a safety benefit to being in remission that has been consistently shown. So I think this table is really important. It shows the safety of the 45 milligram dose for sure in induction, and it gives you some confidence in the induction portion. Next slide. I'm going to speed up a little bit because I realize I've been talking for a long time. I do want to highlight this. This is long-term safety data. This is well outdated now. So this is presented by Remo at UEG last week. And 3 days ago, he presented the updated safety data out to actually 3 years. And 3 years on in therapy in IBD, in ulcerative colitis, there's no signal for, there's no clear signal for malignancy, no clear signal for VT, and no clear signal for MACE. So I think it highlights the fact that in an IBD population that's generally young, healthy, and without other comorbidities, this winds up being a very safe therapy, even in the long term. Next slide. This is a similar safety data in Octave. So this is the tofacitinib safety data. I think what I highlight here is that, again, even for tofacitinib, which doesn't give you the same degree of juice from an efficacy perspective, it looks like, the safety profile of this therapy is pretty benign. Serious adverse events, there's no signal for serious adverse events over placebo. For sure, there's a herpes zoster signal. Like in this case, there's 13 cases of herpes zoster compared to 1 in placebo, but we can protect against that. No cases of malignancy. There is a signal, I think, for non-melanoma skin cancers, and I think that will be borne out long term. But in terms of, if you look at the bottom row, adverse events leading to discontinuation, that rate is actually half in the TOFA group compared to the placebo group. Next slide. And I'm going to pass it back to Tom now first to show you the safety data in rheumatic diseases.
I think it's always insightful to see in other diseases, especially diseases that we aren't maybe managing directly or as the first specialist involved in the GI diseases. In rheumatology, there are a lot of diseases where we use JAK inhibitors. You can see the 3 top ones here for this safety analysis in psoriatic arthritis. AS is ankylosing spondylitis, which is the type of axial spondyloarthritis that actually causes radiographic damage. The one below that is non-radiographic axial spondyloarthritis. So just as the name implies, they don't have radiographic damage, but they've got lots of inflammation on an MRI. So in these three groups, and then the pooled group overall, we're really looking at the same different risk profiles as Chris just described in the IBD populations. Serious infections, including COVID-19 related infections, were studied in the head-to-head program of upadacitinib versus adalimumab. And I'll point out that UPA is being used at the 15 milligram dose here. That's all we use in rheumatology. And then adalimumab, which you know very well, is 40 milligrams every second week. And what you see is a slight increase in risk in the psoriatic arthritis population with upadacitinib compared to adalimumab for serious infections, but not with axial spondyloarthritis, which is interesting, but I think reflects the background risk of that patient population. Patients with psoriatic arthritis tend to have multiple comorbidities, tend to be older, and so you may see increased risks emerging in that patient population that we don't see in the younger, healthier axial spondyloarthritis population, which might be more similar to IBD patients in general, just my opinion. And then herpes zoster, of course, as we expect, we do see an increased rate of zoster infections, shingles and psoriatic arthritis, as we do in axial spondyloarthritis. No surprise there compared to adalimumab, the red dot. But really no differences again with the other three. So malignancy, MACE, and VTE, you know, across the board, no clear signal for increased risk in any of these patient populations with upadacitinib compared to the TNF inhibitor. Tofacitinib, we can look at exactly the same thing. Again, you can just draw your eye across the top. So this is in patients with rheumatoid arthritis now. MACE events, no clear signal for tofa there in the Corvitas registry at 5 years, or the phase 3 RCTs. Malignancy is not showing an increased risk here. Serious infections not showing a difference, again, versus biologic DMARDs. But herpes zoster does emerge, and this is exactly the profile that we do expect to see. The caveat here, I will say, though, is that we do have different data from a safety trial and the oral surveillance trial, which you've probably heard about many times, was looking at thousands of patients that were randomized to either tofacitinib 5 milligrams twice daily or 10 milligrams daily, or to a TNF inhibitor, and followed specifically powered to detect safety differences. And there was a very small but statistically important difference in MACE events and malignancies in the oral surveillance study that was not borne out in these other, you know, Corvitas registry, so real world registry data or pooled RCT data. So that, you know, gives us pause in the RA patient population with tofacitinib as well, that there might be some safety signals there. And I think certainly the dose escalation that Chris alluded to that shows an increased rate of these events with the higher dosing certainly is what we see in the rheumatology population. So really reassuring from the standpoint of seeing similar trends in multiple different disease populations where we're using JAK inhibitors, so we can truly understand what the risk profile is. So that's kind of the overview of efficacy and safety, and thinking back to our case now, this gentleman who unfortunately has multi-drug refractory psoriatic arthritis and is now presenting with emerging IBD. He's on upadacitinib. Most of the people attending here wanted to increase the dose of upadacitinib. Chris, is that what you would do, or what other treatments would you consider?
Yeah, I think for me it would be bumping the dose of the UPA. So he's got a long ways to go. Yes, he's a 62-year-old guy, but really the risk profile, even within oral surveillance, doesn't really start until you're over 65 in male and have that smoking history. So I think I'd be comfortable trying to get him up and see if we can get control, especially because it's controlled his other manifestations really well. So I'm probably of the opinion that I don't want to lose where we're at. I'd try and give it a push and see where we can get to. What about you, Tom?
Well, I mean, I always defer to gastroenterology for these cases, but certainly a lot of my colleagues will think about switching to a different mechanism of action as well. I see that quite a bit. TNFs maybe wouldn't be your first idea because he didn't really respond from a PSA or psoriatic arthritis standpoint to TNFs. And I'd be quite worried about switching to vedolizumab because we know that has virtually no impact on control of arthritis. So that would be worrisome. I would certainly favor trying to make a go of it with the higher dose of upadacitinib, and if you can get that IBD well controlled within 12 weeks, I think we'll all feel much better, and then hopefully you can bring it down again and still maintain remission. But that, of course, would be a challenge that we'd have to try to overcome.
Tom, can I ask you about IL-23 therapies? Because we've heard, it's really emerging in IBD now. We've had one IL-23 on the market for a few, or two IL-23s on the market for sort of the last 2.5 years, but it's really coming to the forefront. Like, what's your view of IL-23 therapies in patients with inflammatory arthritis?
It's one area where we definitely diverge from dermatology and gastroenterology because we've all been impressed at the efficacy of risankizumab and guselkumab and other well, in the IL-23 class basically, and 12/23s to be honest. In terms of GI benefit and especially skin. I mean, it's the gold standard in skin. But unfortunately, we don't see nearly the same potency of effect on arthritis, and I'm speaking now really about peripheral arthritis. You can get some patients to improve, but it takes a little bit longer, and maybe just don't quite get the same depth of control. I'm talking on average in trials, and certainly in clinical practice, my experience would be some people are better, but not overwhelmingly so. And if you're talking now about axial disease, where we've got, ankylosing spondylitis or non-radiographic axSpA, it's basically not indicated at all. So it kind of tapers off in terms of benefit with IL-23s for us. And in this guy's case, unfortunately, he had not had a good response to guselkumab. Don't know whether risankizumab would be another option. It would be worth discussing.
Cool. There's also one of the things probably it'd be good to address it here because I think it's another area we maybe have diverging opinions on. Would be, do you guys use methotrexate in combination with a JAK inhibitor?
Yeah, so that was the question that came up in the chat, and so we do all the time. And combination therapy is the rule, not the exception, in the management of rheumatic diseases. And very commonly, patients are on methotrexate, or they're on leflunomide, or hydroxychloroquine, or sulfasalazine, or some combination of these four before they go on and start an advanced therapy. And we add it on top. We don't stop the other therapy and bring in a different one. No. We add and combine, and we first achieve remission before we dare to take something away. And I think part of it is just because the mechanisms of our diseases are multifactorial. There's multiple mechanisms in play, and you need to hit them all to really get true efficacy. So we're used to doing that, methotrexate in combination with upadacitinib. You probably pay a bit of a price in terms of cytopenias, but pretty mild stuff. And I would say it's pretty darn effective in combination. So I wouldn't really hesitate to do that. Now, different story if you're talking about 30 or even 45 milligrams. I don't know. What are your thoughts?
Yeah, it's an interesting area because our trials diverge really far on this in this scenario because obviously you guys continue. For us, actually, all of our trials were done without the use of methotrexate or azathioprine or other sort of what I'd consider to be sort of non-selective immunosuppressant therapies. So we don't really have that's an area where we don't have much data. Those were prohibited medications in our trials, but I think we're probably accumulating some more real-world type data around this now that we manage a lot of patients together and often have them on both things. So is that a safe combination therapy? I think at the IBD doses, we don't we don't know the answer to that. I would say that would be probably the unsatisfactory, but sort of data-driven answer at the moment.
I would do it with great hesitancy at those higher doses. So I think speaking to Usha's concern here in the chat. So yeah. But at 15 milligrams, I wouldn't be nearly as fussed about it. And anything that gets rid of the prednisone, in my mind, is usually a good thing.
That's a good point. Great point.
So we should think about the evolution of therapies, and I won't spend a lot of time on this slide because you guys all know what these medications are. I'll just point out in spondyloarthritis that after the advent of TNF inhibitors, which are of course indicated for rheumatic diseases and dermatologic and gastroenterology diseases, we also had the assistance of apremilast in psoriatic arthritis and abatacept, which is a T-cell co-stimulatory inhibitor in psoriatic arthritis. And then the IL-17s, which of course are not used in the management of IBD. Interestingly, IL-23 is, IL-17 is not, so they're clearly different mechanisms. We have ixekizumab, secukinumab, and now bimekizumab, which inhibits both IL-17A and F. And then there's the JAK inhibitor story and IL-12/23s, which you all know quite well. The ones we don't use, Chris?
Yeah, so we have a few options. I think probably all of us are quite familiar with using vedolizumab now. It's alpha-4 beta-7 integrin inhibitor that is gut selective in terms of the mechanism. We have really now one S1P receptor modulator, etrasimod. So this is an oral once-a-day pill. It also blocks lymphocyte trafficking. And then mirikizumab is approved in ulcerative colitis. It likely soon will be approved in Crohn's disease as well. And so we'll get the full gamut, I think, in the next year of IL-23 therapies. So that'll be risankizumab, mirikizumab, and guselkumab. And that's, I mean, I think that's sort of the roadmap to 2024. What it looks like beyond that, there's a number of really promising therapies that are going into phase 3 development right now. So hopefully those will come in the next few years as well.
And we love choice, but obviously that adds more complexity. So more to learn, and there's going to be more sharing ahead, I think.
Yeah, for sure.
Did you want to briefly touch on the
Sure, yeah. So I guess, with more choice, one of the questions is, well, how do these different therapies stack up? This is one of the network meta-analyses. This is done by Remo and colleagues. And again, there's several more of these now. I think, as I mentioned earlier, it's pretty clear that at the top of the pack for potency in terms of how effective the therapies are, JAK inhibitors really are the predominant therapy in terms of efficacy. Everything else at the moment in ulcerative colitis, I would say, probably looks pretty similar. So you can see most of the dots are lined up on both the left and the right-hand side here. Next slide. Then the question is, do you pay something for safety? And I think you've heard both Tom and I speak a little bit now about the fact that it doesn't look like that. What's quite interesting is the two right-hand panels, especially. So serious adverse events, serious infections. Do you pay a penalty for using really potent immunosuppression? And what's this trend that's emerged now, I think we've seen this in both very large data sets for like real world treatment registries and across clinical trials, is that there's something that that safety and efficacy wind up being two sides of the same coin. If you stop treatment because the treatment's not working, it doesn't matter what the safety profile of the therapy is, right? So actually, you don't see here an increased risk for any of these three for upadacitinib or for tofacitinib for that matter. You do see potentially increased risk for some of our therapies that I would say maybe are less effective. And here, that example is golimumab, which we don't really use that well or that much. And part of that is because I think maybe you consider that to be potentially a less effective therapy in ulcerative colitis. So I think this slide really illustrates the fact that getting a patient into deep remission in and of itself is protective against some of these adverse events. Next slide.
So if we're thinking about how to manage patients with multiple immune-mediated inflammatory diseases, we got to balance this risk. And the risk that patients usually come in with is, I'm terrified of the risk of the drug. But then we have to really bring up, well, there's also a risk of not controlling the disease, and the risk that discussion is really, really important. Obviously, we want to maximize benefits and minimize risk, but how you go about doing that really becomes a bit of a dance between the provider and very much the relationships that our patients have with their nursing team is really, really important. That therapeutic alliance we know is very, very strong. Patients listen very closely to what their nursing team says. And so I can't underscore enough just how important these discussions need to be. What is borne out, and Chris has already spoken to this, is that tight control of the disease actually lowers your overall risk. Your risk of serious infections goes down when your disease is in remission. And part of that is because you need less prednisone, and we know that's a big driver of risk. But also the disease itself impairs your immune function. Risk of VTE is way higher whether you've got high activity psoriatic arthritis or high activity Crohn's. VTE risk is much higher, and so are other major complications. And it's not all just the medication risk. So the focus needs to be on, how do we control the disease to minimize those risks? And then let's also try to adjust the risk related to medication, but we can't even begin to address that until we get the disease under control. So a bit about counseling, and I don't know, Chris, would you add anything to those sorts of tips, or how do you discuss it with your patients?
I wish I could have recorded you and then just played that back. That's really eloquently said. I totally agree. I mean, I think the point that we all deliver the same message is really important. I think when people are afraid of therapy, it's not coming from a bad place. It's coming from the fear of, in many cases, an act of commission, that I'm doing something that increases my risk, but sort of understanding that doing nothing also changes what their risk is really critical. And I agree with your approach completely.
Brilliant. All right, so we've got a few other questions, but I think for the sake of time, we should maybe move on to the second case.
Sure. So the second case is, yeah, I can sort of present this case. This is Frank. He's 55. He loves playing hockey, even though he's one of those typical guys who can't accept that maybe his professional hockey career is over. But he is an active guy. He's had left-sided ulcerative colitis. Initially had budesonide MMX, tried 5-ASA for maintenance, did well originally, but then lost response after he stopped taking his medications. I think that's probably a story as old as time for us. I would say that for many of us, vedolizumab is a go-to first-line therapy in ulcerative colitis for lots of good reasons. Excellent therapy, incredibly safe, high degree of efficacy, better efficacy head-to-head than adalimumab. And so he starts vedolizumab, does well initially, but starts to lose response after about 9 months. So he gets bumped to every 4-week dosing. With that, he needs a bit of prednisone, still has a fecal cal of 650. His ferritin's low, his hemoglobin's low. He's having 5 to 8 urgent bloody bowel movements. And he's going once to twice at night. So I think we see this a lot, right? Not under control. And with that, he's got new onset inflammatory back pain, morning stiffness, and on plain films, he's got sacroiliitis. He now really has to stop playing hockey because of both urgency of run into the bathroom and back pain. So with that sort of profile, we'll bring up the poll, and you can let me know what you think in terms of switching to a TNF inhibitor, switching to a JAK inhibitor, or switching to something else.
Right. So it sounds like he's got active IBD, and now he has ankylosing spondylitis, which, by the way, that risk is really, really high. We know the association of having ANK-SPON is highest in the IBD population, higher than like say our psoriasis patients. You're more likely to end up with ANK-SPON if you've got IBD. So it's an important association. We need to be screening for it. So we just switch to a TNF, switch to a JAK, or do something else. All right, a little more equipoise here. most people want to switch to a JAK still, but 30% want to switch to a TNF.
Interesting. Very good.
So yep, we got our approved therapies for AS and UC, and of course TNFs are on that list, so are JAKs. As I mentioned before, not really the IL-23s, certainly not for axial disease, not something we would really reach for. So it's a shorter list of options here. What would you like to do, Chris? Oops.
I'm okay either way, honestly. I think this is one where if my rheumatologist feels like they have a strong preference, I'm happy to defer to them. I think the key thing here is getting their bowel disease under control, right? Because it's hard to know if hard to know how much of those axial symptoms are going to improve with the bowel disease under control, how much of those are going to be residual. I want to have something that'll cover both of them. So I think both a JAK inhibitor and a TNF, both are reasonable. What about you, Tom?
I totally agree. And I think, we're really happy when GI is involved and they can really crank up the dose of the TNF. And that's often a good option for our patient. And the same thing with the JAK inhibitor. So you guys have access to a larger hammer than we do. And that's sometimes a really good thing.
Sometimes we don't use it appropriately. It's got to be the hammer and the nail. That's the combination. That's right.
So there's a couple of what if scenarios. So maybe we can briefly just give our quick hitter opinions on these, and then we can wrap up. Would it change your opinion if the patient had non-melanoma skin cancer, or let's say a lung cancer?
Yeah, I mean, I think for us, the big question is what was the cancer? What was the staging? How long ago was that? And then for a lot of patients, it's sort of the fear that comes with that. Of course, both TNF and JAK inhibitors have been associated with non-melanoma skin cancer. So for me, in this case, it's either way, they're getting monitored by someone who's got a keener eye than myself for looking at the skin.
Yeah, fair enough. And I guess if it's an RA patient, we might think a little more TNF, but that wouldn't apply in this case.
What
What
about
about a DVT?
Yeah. What about you for this case? If they had a DVT in the past, what's your thought process around that?
I mean, again, in the upadacitinib program, there really wasn't an increased signal for VTE, so it's not something that I would really put a lot of weight on, especially if we're switching to UPA. But TNFs are certainly quite reassuring from a data standpoint, and I would be very comfortable with the TNF in this case.
I think for me, it really depends if they're on anticoagulation or not. If they're on anticoagulation already, the magnitude of risk for VTE in someone who's on anticoagulation and a JAK inhibitor is really small. For the most part, we plow ahead and treat if they're already on anticoagulation.
Right. Yeah, no, exactly. If they've got the anticoagulation, you don't worry. But for this one, it sounds like it's a provoked but stopped anticoagulation. So it happens. And then the final one is the female sex with reproductive age. How does that change your decision? Probably pretty straightforward.
Yeah, obviously it's a no-go for a JAK inhibitor in this situation if they're wanting to have kids. Of course, not everyone wants to go down that path, right? So if someone tells me that they're not planning on having kids or they're on reliable birth control, I think I'm open to the discussion of both therapies. If they really do want to do that, I think I'm leaning TNF.
Yeah, I would agree with that.
Tom,
Great.
can I ask you what you do for routine monitoring? It's in the chat as one of the questions. What do you do for routine monitoring and frequency of that monitoring when you're on a JAK inhibitor?
Right. So our habit, for better or worse, is to monitor blood work every 3 months. And if we're starting a new therapy, starting a JAK inhibitor, it would probably do it monthly for 1 or 2 measurements, and then go to every 3 months after that. So that would be pretty much for every DMARD, not for TNFs, not for a lot of the biologics, but certainly for JAK inhibitors, small molecule inhibitors, and conventional DMARDs. That's what we would normally do.
Yeah, we're probably pretty similar. We'll measure a lipid profile before and after one time. Like usually I'm sort of a week 12 to week 24 kind of person for a one-time lipid check. but I never check their CK. It's clinically irrelevant, and I'm not a huge fan of getting irrelevant blood work back. It's got enough in my inbox. So,
I think
but
that's a
otherwise,
good point, though. The lipids waiting until after you've got good control of the disease is probably the best, because you can get those falsely low LDLs and be falsely reassured. So it's important to time it properly. Good. Well, that kind of brings us to the end of the cases and the program discussion, and we're actually at time. If there's other questions in the chat, maybe Barb could pop back and let us know if there's anything else.
Yeah, I'm not seeing any other questions, only the question, I think you answered them all. Just the low, would you be using low dose methotrexate in combination with your Rinvoq? Or sort of a higher dose? Like for us, it would be, max dose 25 milligrams, low dose, we would consider 12.5. Like what would you be using in combination with your Rinvoq?
Yeah, so interesting terminology. So we certainly think about high dose methotrexate being from the cancer literature, and people getting
Yes, yes.
IV dosing, and 10, 100-fold higher doses than we would use in either GI or rheumatology. I wouldn't necessarily change the dose from 25 to 15 or anything like that just because we were starting upadacitinib. I would just continue with the current dosing, and then as we were talking about with the blood work, if the blood work suggests that we're getting anemia or something like that, then certainly can make some adjustments later. But no, we want to stamp out the inflammation and then see what we can do after that.
It's a fascinating presentation tonight, particularly with the combination of the JAK and the methotrexate. For us IBD nurses, we've been kind of schooled in that's a no-no. And I found that really encouraging to have a few more tools in our toolbox, even though our JAKs are a little bit higher dose, obviously. So I thank you, Dr. Appleton and Dr. Ma, for joining us tonight. Excellent presentation. I don't see any other, there is one other question, if we have time. Do you ever see anti-TNFs causing vasculitis? We currently have 2 pediatric patients with severe small vessel vasculitis, and rheumatology is asking us to switch.
Really interesting case, and I think these things do come up periodically. Once every year or two, we'll hear about some very unexpected consequences or drug reaction. I don't know the details of this case. Maybe there's other factors, but yes, there's a host of drug-related phenomena that can be related to, or actually present like a rheumatologic disease, including vasculitis. I'd say other things happen a bit more commonly. So with TNFs, you can have paradoxical psoriasis, for example, often presents with an inverse psoriasis kind of pattern. And so, yes, you can see that sort of thing happening. Sarcoidosis, lung reactions, these sorts of things. They're all so rare that, you read about them in case reports, not even frequent enough to pop up in clinical trials very often, but it's out there. It's something that can happen, and sometimes it is just easy enough to change the medication. So it sounds like you've got a good rheumatology consulting team working with you.
Yeah. Okay. I think that's it. Oh, let me just check here. Yeah. No, that's it. Again, thanks for a great presentation. And thank you to everybody who has joined us this evening. Hope you have a couple of good takeaways. I know I sure do. And you'll get an evaluation. Narissa, did you say the evaluation will be in the chat or will come in their inbox?
It's like it'll pop up in the browser once people...
Yeah, pop up after. Perfect. Well, thank you, everybody. And have yourself a fabulous evening.
Thank you. Good night.
Good night.
Thanks for having us. Have a good night.